Hello, everyone. Welcome to the webinar, Analyzing and Interpreting Caregiving Data in the BRFSS. This webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. A question and answer session will immediately follow the live presentations. Throughout the program, we will be accepting questions through the questions feature, which should be accessible on the GoToWebinar panel. Our speakers for today's program are Dr. Erin Bolden and Dr. Benjamin Olivari at the CDC Alzheimer's Disease and Healthy Aging Program. Without further delay, I'll hand the microphone over to Dr. Erin Bolden. And it should be coming over to you now.
Judy, good morning, everyone, and thank you for joining us. You all see this main slide here?
Great.
All right. So before we get started, I just want to mention that Ben and I have no relevant commercial relationships to disclose, and also that the findings and conclusions we'll talk about today are our own and do not necessarily represent the official position of the Centers for Disease Control and Prevention. And today I want to start by setting up the topic of caregiving as a public health issue, and really just to set the stage for what kind of caregivers we're talking about. We are discussing informal caregivers, so those family members and friends who care for people typically in the community. These could be family members, friends, or others, so sort of outside of the healthcare system, and they really form the foundation for long-term community-based care in the US and are a critical component of enabling people to age in place. And we know that caregiving can bring benefits to caregivers, so it can provide a sense of purpose. It might foster closer relationships with the person to whom they provide care. But we also have some evidence to suggest there are some negative health effects, many of them stemming from stress and burden associated with providing care, and that could be physical, emotional, financial, or otherwise. And there's also been some data to suggest that caregiving is associated with chronic health conditions and mortality. So for these reasons, caregiving really is a public health concern. It affects the health of the population, both caregivers and care recipients. We know that there are particular subgroups of people who are more and less likely to be caregivers. So there's some health equity issues inherent within caregiving. For example, women tend to provide caregiving more often than men, and there are other demographic and similar differences. And finally, we have some effective evidence-based programs that can support caregivers, so they can kind of mitigate those negative effects, reduce burden, reduce negative health outcomes. So since this is a public health issue, caregiving is a public health issue, one of the major components, one of the traditional core functions of public health as a field is assessment. And so surveillance, or the systematic collection of data and information on health in populations, falls within that assessment core function. And one of my favorite quotes related to surveillance is from former Surgeon General David Satcher, and he said, "In public health, we can't do anything without surveillance. That's where public health begins." So we really do see it as a foundational component. And so collecting information at the population level about caregiving is really important to inform our activities, our priority setting, our policies around caregiving as an issue. And so while caregiving research has been going on for decades, the specific focus on surveillance, or collecting data on a really representative sample of the population, is relatively recent. And so that's what we're going to spend some more time talking about today. So brief history of this caregiver module. And let me tell you, before I get too far, just a little bit about the behavioral risk factor surveillance system itself. So I will note this is the third in this webinar series, and so some of you may have already heard this, so I won't spend a lot of time talking about BRFSS. But for those of you who aren't familiar, the behavioral risk factor surveillance system is a state and territory based surveillance system within the US. So CDC sort of aggregates the data across all the states and territories that participate. And the structure is such that there is a core set of questions that every respondent, and I should mention BRFSS, samples people 18 years and older who are not living in an institutional setting. And so among those respondents, all of them answer this core set of questions that is part of the BRFSS each year. And then there's kind of a long list of optional modules that have gone through some additional testing and evaluation to be included on the list of optional modules. And states and territories can select which of those, if any, they want to use in particular years. And one of those options is the caregiver module. So states are not required to use any particular module. They're not required to use them with any specific frequency. So it really is a jurisdiction-based decision. So the module came from, it was developed starting in 2004 by Dr. Elena Andreessen, who's an epidemiologist, and it was developed with input from an expert panel on caregiving. It went through some cognitive testing, and then in 2005, North Carolina included the caregiver module questions as a pilot on its behavioral risk factor surveillance system. And the module was originally developed to meet one of the objectives from Healthy People 2010, which involved increasing the number of states that had surveillance information on people with disabilities and their caregivers. So that was sort of the motivation for it. Here's more details about the timeline. So as I mentioned, it was first piloted in 2005. Then there was some funding available to help 3 states adopt it in 2007. So Hawaii, Kansas, and Washington did that. In 2009, it was formally approved as an optional module for the behavioral risk factor surveillance system. And also in that year, the first question, that what we call the screening question, which I'll talk more about in just a few moments, was actually included on the core. So we did get sort of national prevalence estimates for caregiving using that. Then beginning in 2013, we started doing some revisions and additional testing on the module. And starting in 2015, there was a revised version of the module available. So the data that I'll be focusing on today start with that 2015 administration, since there were some changes in that year. And there have been a few changes since then, some of which I'll also describe as we go along. So this map here, this figure shows who has used the caregiver module state-wise. And you can see that most states and territories sometime between 2015 and 2019 used the caregiver module at least one time. This map is just showing the most recent administration. So the dark purple ones are the ones that have 2019 data, which are the most recent available. And I should note that several of these states included the module in multiple years. For example, I believe New York has data for every one of those years between 2015 and 2019. So if you're interested in more details on that, you can let me know, or the BRFSS website, which is cdc.gov/BRFSS, has lots more information about which states use which modules in which years. I should also mention that all of the BRFSS data are publicly available, so you can go on the BRFSS website and download any year of data and analyze it yourself. So this slide gives a short overview of the contents of the caregiver module. And for this presentation, I'm using the wording and the response options from the 2019 version, the latest one. So it starts with identifying a caregiver, which the question for that will be on the next slide. But then if somebody is classified as a caregiver, they answer a subsequent set of questions about themselves and their care recipient. So they report on the relationship to the care recipient, how long they've been providing care, on average how much care they provide, what the care recipient's main health problem or disability is. And then starting in 2019, there's a follow-up question on that health condition one, asking specifically if the person also has Alzheimer's disease, dementia, or another cognitive impairment disorder. And then there's 2 questions getting at the type of care provided. So the first one asks about whether the caregiver helps with any personal care, things that are sort of like activities of daily living, and also whether they help managing household tasks. So those are more IADL kind of activities. There is one follow-up question. So if somebody says in response to the first question that they are not currently providing care to someone, they are asked one follow-up question about whether or not they expect to be providing care in the next 2 years. And so the purpose of that question is to try to do a little bit of projecting at the state level for what kind of level of supports there might be needed for caregivers in the near future. Oh, I do want to just answer one question that there was about North Carolina, that yes, they actually have not done, I believe they did include the caregiver module before 2015 again at some point, but they have not used it. That's right, between 2015 and 2019. So I want to spend just a little bit more time on each question so you can get a sense of exactly how they're phrased, what the response options are, what might be possible with the caregiver module, and doing analyses with it. So this is the first question on the module, the one that we often call the screener question, and it is: during the past 30 days, did you provide regular care or assistance to a friend or family member who has a health problem or disability? So if someone answers a yes to that question, we consider them to be a caregiver module and they get asked the remaining questions in the module. If they say no, they're classified as a non-caregiver and then get asked the question about whether they expect to provide care in the next 2 years. Likewise, if the respondent volunteers that they did provide care, but that their care recipient died within that time frame, within the last 30 days, they get coded as a non-caregiver and go to the next module. And then BRFSS in all questions has options for don't know and not sure or refused. And so we typically just classify those respondents as missing, and they're also not asked the rest of the caregiver module questions. So the next question is about the relationship. So what is the relationship of the care recipient to the caregiver? And as you can see here, there's a lot of relatively specific response options. Most of them have to do with family members, but then at the end there is a non-relative or family friend option. Caregivers are asked how long they have provided care for the care recipient, and the response options for that range from less than 30 days up to more than 5 years. So this is not an open response question. Like most on the BRFSS, it has defined categories. Then caregivers are asked how many hours per week on average they provide care or assistance. And these categories are sort of based on working amounts, so up to 8 hours, 9 to 19 hours per week, 20 to 39 hours per week, and 40 hours a week or more, which would be sort of equivalent to a full-time job. Next, we have the health condition question. So caregivers are asked, what is the main health problem, long-term illness, or disability that the person you care for has? And so typically the way this functions is that the interviewer would not read this full list of responses, but the person responds and then the interviewer classifies it according to this list of options. And again, you can see most of these are chronic health conditions, but there is a category for developmental disabilities, one for mental illnesses, another for substance use, and one for injuries. During the 2015 to 2019 period, one of the changes that was made was that the injury and the old age, infirmity, and frailty categories were added. This was partly to capture the fact that we had a large proportion of other responses, and those in states that were collecting text responses, they were frequently either injuries or old age, and so we added those to try to capture them. And you'll note that Alzheimer's disease, dementia, or another cognitive impairment disorder is one of the response options for the health recipient condition. And as I mentioned at the overview, there's then this follow-up question, so that if the person didn't identify Alzheimer's disease as the main health condition, they are then asked if the care recipient also has Alzheimer's disease, dementia, or another cognitive impairment disorder. And then the caregiver is asked, again, what types of care they provide. So the first question is whether in the past 30 days they provided care by managing personal care, such as giving medications, feeding, dressing, or bathing. And they can say yes or no to that. And then also whether they helped with household tasks, like managing money or preparing meals. And that, again, is a yes or no response option. So I do want to mention a few things about analyzing BRFSS data in case you're not familiar with it. So because BRFSS is designed to represent each state or territory's population, data have to be weighted to accurately do that. And the public file that's available on CDC's website has all of the weights included, so you don't have to do any calculations yourself to weight the data, but you need to apply appropriate weighting procedures when analyzing the data. It's also worth noting that many states use multiple versions of the BRFSS questionnaire, and typically most states have at least 4,000 responses overall to their survey. And just from looking at the caregiver module data over the last few years, I would say in general, most versions have at least 2,500 respondents to them. So they're still pretty substantial. And on average, it's more like 5,000 respondents per questionnaire version. So there are typically plenty of both responses to the caregiver module and also caregivers that you can do meaningful analyses at the state level. It is also possible to combine multiple years of data, and you could do this both within a single state or across states. And there are at least two approaches. The two that I mentioned here are just keeping the most recent year of data, which means you can also just keep that year's weights, since each state or territory would only be represented once in your data set. You wouldn't need to modify the weights at all. The other alternative, if you did want to combine multiple years of data in which states contribute more than 1 year, you would need to adjust each year's weight so that in aggregate, it is still only one state's worth of information in the data set. So sort of an easy example would be, if New York, since I mentioned they use the module multiple times, if you wanted to combine 2 years of data from New York, and in each year they did about 5,000 surveys, you could just divide each year's weights by half, since each year is contributing half to the overall sample, and use it that way. And then of course the calculations get slightly more complicated when states are disproportionately sized, but you're really just multiplying the existing weight by whatever fraction they contribute to the overall sample in terms of sample size. And again, if you're interested in doing this or getting more information, I'm happy to talk in more detail about that. I also just want to note that BRFSS, although it happens every year, it is not a longitudinal sample. So it's a new sample of people included with each administration, which means that the data are cross-sectional. And so talking about prevalence and therefore prevalence ratios is really an appropriate way to analyze the data. So a lot of these outcomes, even the experience of being a caregiver, is pretty common. About 20% of people on average, although we'll talk more about that in a moment, report being caregivers. So that's a pretty common experience, meaning that the odds ratio is not going to be a great approximation of the prevalence ratio. And so there are ways to analyze data to account for that. And I have one citation here at the bottom for both an article that describes why you might use things like a generalized linear model with a binomial family and log link to estimate the prevalence ratio rather than just standard logistic regression. And they also give some examples, including code, if memory serves. And speaking of code, we also have some code available. So the team at the Alzheimer's Disease and Healthy Aging Program put together a document that's available on BRFSS's website that talks through some of the, basically goes through each of the questions as I just did, but provides code to go along with them, some recommendations about how you might think about analyzing data and more details. So if you're actually doing this on your own, that document should help you substantially through the process. So before I hand it over to Ben, I do just want to give a couple of brief examples I'll be talking on this slide and the next one about data that came from an MMWR on the caregiver module that we put out last year. And this MMWR aggregated data from 2015 to 2017. It included 44 states, the District of Columbia, and Puerto Rico. And overall, 20.7% of adults age 18 and older were classified as caregivers using the caregiver module. But there was a pretty wide range, as you can see in the figure that's on the right side of this slide. It went from 13.7% of adults in Puerto Rico to 28.2% of adults in Tennessee. And the figure that is showing here is alphabetically listing states and then showing the prevalence estimate of caregiving for each one. In addition, about 1 in 6 adults, or 16.7% of non-caregivers, said they expected to become a caregiver within the next 2 years. So some useful information about both how many people currently are providing care and what the projections might look like in the near term. As part of this MMWR, we also looked at health status among caregivers, and about 1 in 5 caregivers rated their general health as being either fair or poor. And this map that's showing on the slide here is one of the figures from MMWR that just shows the state level prevalence of fair or poor health. And again, there was quite a wide range. It went from 11.7% of caregivers in Minnesota rating their health as fair or poor to just over a third of caregivers in Puerto Rico saying their health was fair or poor. And I want to say just a few more things about using the caregiver module. Of course, on its own, as we just demonstrated, you can look at the prevalence of caregiving, understand a little bit about the health of caregivers and their characteristics. But it's also one of the great features of the behavioral risk factor surveillance is that because it asks about so many different topics, you can also combine anything that was on the core with the caregiver module, and if another optional module is included on the same version of a questionnaire, you can also look at that by caregiver status. So for example, if you're interested in caregivers, let's say college-age students who are college-age people who are enrolled in school as students who are caregivers, that would be possible in the BRFSS. Or if you want to focus specifically on African-American caregivers who are also employed, who are working currently, you could do that because there are questions about employment status on the core of the BRFSS. So looking at the core questions are worthwhile. I'll just sort of summarize. There are a number of health behaviors, things like alcohol and tobacco use. There are immunization questions, there are physical activity and nutrition questions, and then there are cancer screening and other types of health behavior questions. Along with, as you saw before, there are questions relating to health-related quality of life, so general health status, frequent mental distress, disability status, a variety of chronic health conditions. So lots of options to consider, to explore using the caregiver module combined with other components of the BRFSS. In summary, I just want to say that the BRFSS offers a unique opportunity to estimate both the prevalence of caregiving and describe the characteristics of care at the state and territorial level. And again, it's possible to look at both subgroups of caregivers within the broader population and also look at a variety of their health-related characteristics. So with that, I will turn it over to Ben, and he is going to share with you some more options for using and exploring these data.
Thank you so much, Dr. Bolden. And the things I'll be presenting will be closely linked with the information that Dr. Bolden just presented. So what I want to go through is some of the more practical ways in which we have used the data and in which the data can be used from the caregiver module in the BRFSS. So the first of which is a data brief series that we developed in collaboration with the National Association of Chronic Disease Directors, or NACDD. So we created 4 briefs using BRFSS data, and I do want to specify that these data are from the years 2015 to 2017, so they are about a year and a half old. We created these 4 briefs focusing on different subject areas within public health that are important among older adults in the US. So those are cognitive decline, caregiving, coronary heart disease, as well as the relationship between chronic diseases and cognitive decline. So these briefs focus on persons age 45 years and older, and they look at things like how prevalence varies across states, how demographic plays into some of the prevalences that we see. And it also provides some specific evidence for various policies and decision-making processes related to these specific aging areas. And it provides action steps for stakeholders and other public health officials at the end of each of the briefs. The briefs are about 10 to 15 pages in length. And I'm going to take you through the caregiving one, just with a couple examples of the kinds of things that are included. So the caregiving data brief specifically looks at things, again, like the characteristics of caregivers. So demographical information such as race, gender, and ethnicity, as well as the age. And here we looked at persons aged 45 years and older, but we also broke out those age categories so that we can look at persons in that older middle-aged group. So persons aged 45 to 60 and 65, versus the older adults, 65 years and older. We also looked at various other information that comes from different modules within the BRFSS, so things from the core module as well as some of the other optional modules. So that would include whether persons who are providing care also experience cognitive decline, what their health status is, and things like of that nature. And I'm going to just show you one example in which we've used that data. So here you can see we created a map that looks at how frequently reported mental distress was among caregivers. And this is, again, for caregivers specifically aged 45 years and older, although the BRFSS optional module does capture caregivers 18 years and older. And you can see here that frequent mental or physical unhealthy days can be tracked by linking that caregiver module data with some of the data from other modules within BRFSS. And what we found was about 14.5% of caregivers reported experiencing 14 or more mentally unhealthy days in the past month. So that would be something like stress or depression within the past month. We did also find that about 17% of caregivers experience physical unhealthy days as well. So another interesting piece of information is whether or not caregivers are getting enough sleep each and every month. So we defined in the BRFSS question that looks at insufficient sleep as fewer than 7 hours of sleep in a 24-hour period. And again, this is something that's critical to whether or not a caregiver is taking care of their own health in addition to the person for which they're caring. And we found that nearly 40% of caregivers, or about a third of caregivers, reported getting insufficient sleep. So that would be less than 7 hours in a 24-hour period. As Erin mentioned, we can also look at the future burden of caregiving and try to anticipate the specific populations of caregivers that might be affected. So here you can see that we captured across different states what the prevalence of persons who are not currently caregiving but expect to be caregivers within the next 2 years were. And among persons 45 years and older, we found that about 17% of those persons expected to be a caregiver within the next 2 years. And more specifically, we found that those persons tended to be among the younger, older side. So that would be the persons 45 to 64 years. About 20% of those persons who are not currently caregivers expect to be caregivers in the next 2 years, whereas about 12.8% of adults 65 years and older expect to be caregivers. So currently, if you think about the landscape of caregiving, many caregivers are themselves already currently older adults themselves, but as we anticipate the growth in the older adult population, just based on the demographics of the United States and the growing proportion of older adults, we do expect that those persons who are in the middle-aged groups here that we pulled out as 45 to 64 will have an increasing share of providing that care within the United States. So another tool that the CDC produced using this BRFSS data is the Alzheimer's Disease and Healthy Aging Data Portal. So if we access that portal, we can find national and state level CDC data. So again, national means aggregated data across multiple states as opposed to national surveys across all states. And they look at things like caregiving, cognitive decline, other overall health factors such as screenings, vaccinations, as well as mental health. And it's useful because we update these actually each and every year. And we're able to look at kind of the currently available surveillance data for older adults. And we're able to think through kind of what the next steps could be using these data. So to access the portal, you can visit either cdc.gov/aging/aging data, or you can go to our website and navigate to the data and statistics sidebar menu and navigate to the aging data portal. Or if you just Google CDC aging data portal, it should be just about the first or second hit on Google. So this is what the page will look like when you visit. You have an option to select the location. So that could be the United States aggregated data, or you can select specific states. You can also select by category on the right side, or you can actually create your own custom reports. And that is a bit complicated for lay users, but I encourage you to play around and see the kinds of things that you can produce using that feature. So here I'm going to just show you, these are the different regions and states that populate. And then I'm going to just select Georgia, so one state, and this is what will populate. It'll actually originally populate with overall health, but I'm going to navigate to caregiving and show you what that looks like. So now that I've gone to the caregiving category, we can select specific years in which you're interested. So if you select the most recent year, that again will select the most recent year that that state, or if you select the aggregated United States, the most recent year that the optional module was administered. But you can also do some of the previous states if you're interested in a specific year in which the state of interest administered those modules. And then a neat feature is that you can actually pan between the bar graph form or the table form. And what's nice about the table form is you can easily pull out the specific prevalences and 95% confidence intervals. And I'm actually going to just give you a quick tour of what the site is like in here live. So I'll just do the United States aggregated data. And as I said, it will populate overall health first, but you can see there are several different categories: caregiving, cognitive decline, mental health, nutrition, physical activity, and several others. I'm going to click on caregiving, and then I'm going to select 2015 to 2018, which is the most recent data that's currently available on the website. And here you'll see this is the aggregated data. And what's neat about this is you can actually select specific age groups of interest. So here, since this data portal focuses on primarily the aging population, we can select either 50 to 64 years or 65 years and older. And you can stratify even further by things like gender, or you can look at things like race and ethnicity. So that's just kind of a taste of the sorts of things that you can do, but I encourage you to do so. And like I said, you can use the table form, or you can actually create your own custom report if you have a specific kind of analysis that you're interested in producing. We did also produce some more user-friendly infographics specifically on caregiving. So all of these infographics have the data from the caregiving optional module through the BRFSS. This one here is the aggregated version from 2015 to 2018, and it'll have the various responses from that optional module that Dr. Bolden just went through. So the overall number of caregivers, how often they provide care, and things of that nature. And you can also pull out the specific state of interest. We have infographics for each state in the years that they administered those modules. So I encourage you, if you're interested in a particular state, to check out the website. You can print off an infographic for a specific state for a specific year if you're giving a presentation or if you're in a meeting. And you're just trying to give a brief overview of kind of the caregiving landscape at that year, at that moment in time. We also have more specific caregiving infographics that are stratified by race and ethnicity. So those include African Americans, Hispanics, American Indian, Alaska Natives, and Asian, Hawaiian, and Pacific Islanders. And we also do have gender-specific caregiving infographics. So that would be with women, men, and LGBT. And all of these infographics that I've just showed you here can actually be pulled in Spanish translation. So those, all of that content is available in Spanish if you're working with a Hispanic population, or if you're in a state that's has a high prevalence of Spanish-speaking community members, and you're interested in that as well. We do have several other resources on the website that are focused on caregiving. So one of which is the Supporting Caregivers Healthy Brain Issue Map. So this issue map accompanies our state and local public health partnerships to address dementia 2018 to 23 roadmap. And what these issue maps do is they provide some action steps that public health officials and other stakeholders can take related to caregiving, specifically with a lens towards cognitive decline and Alzheimer's. And they do provide some specific examples of the initiatives that states have taken to address issues like caregiving. So if you're interested in some success stories, those are in there. We also do have one that's specific to data and evidence. So that's not exclusive to caregiving, but it talks a little bit about how we can use data to inform decision-making processes in public health, how we can use data in more effective and practical ways. And that this does, again, focus a little bit more on how BRFSS data has been used, but there are other examples as well. So that concludes my portion of the presentation. I did also want to point out that there is one more webinar in this series of webinars, and that's with the Alzheimer's Association next week at the same time, and that's with Matthew Baumgart and John Sheen, and they'll talk a little bit more about how the BRFSS has been used to inform public health action and impact the public health community in the ways in which we can improve these populations of interest that are captured in the BRFSS. So with that, we have some time for questions. So I'll turn it back over to Judy and Erin, and we'll get through some of those questions. So one of the questions that was asked is, in Wisconsin, family members and friends can get paid for providing care assistance through waiver programs. Does the module capture those that get paid versus those that don't? So that's a really good question. And one thing about the BRFSS is it's not linked to any sort of external databases. So things like CMS data or Social Security data, other health data. It is just all self-report. So if a caregiver is responding to that optional module and they self-identify as a caregiver, we don't really link that to, say, a specific program in a specific state. If they, self-identify themselves as caregivers, that's how they'll be captured. If they do specify that they're caregiving for a friend or family member.
Yeah, and I would just add that it is possible, each state has a BRFSS coordinator, each state and territory. They are listed on the BRFSS website if you don't know who yours is. But it might be possible, if Wisconsin is using or other states are using the module in future years and you do want to know an additional detail that's not captured in the module, you could probably work with your state coordinator to add a question as a state added question that sort of supplements the module. Ben, do you want to take the next one or do you want me to?
Sure. So another question that was asked is, what are the relative advantages of the BRFSS Caregiver module compared to other nationally representative data sets that have caregiving info? Examples would be the HRS or NHATS. So one thing about the BRFSS that's very unique is that we capture this data on the state level rather than the national level. So with those other data sets, the way in which they're capturing and weighting data is actually what was mentioned in this question, which is they're nationally representative. With the BRFSS, they're actually representative by state, which as a whole sort of makes up a nationally representative, but again, they're actually representative by state. So it actually can provide really useful information in planning for states specifically that some of those national data sets cannot, or it's more difficult to tease out that information. And Erin, I don't know if you had anything additional to add.
Yeah, thanks, Ben. And the only other thing I would add is I'm not sure, I can't remember how the health and retirement study samples right now, but NHATS has the National Study of Caregiving linked to it, which is fantastic and an excellent resource. But because NHATS itself samples from Medicare eligible adults, it only samples older adults, and so only their caregivers are included. And so the BRFSS is also a little bit different in that it could be a caregiver for someone of any age. You may have noticed that we don't specifically ask about age, but we ask about relationships, so you can sort of infer if someone's, if someone says they're caring for their child and they are in their 30s or 40s, you know that that child is probably young. So that is one difference as well. You capture a slightly different, well, the whole population is potentially included in the BRFSS, while some other data sources just focus on older adults.
Another question that was asked is there a mechanism to get the graphics that are being presented if, say, you wanted to use them in something like a class? Again, if you visit our website at cdc.gov/aging, all of these infographics are available there, and they are accessible in PDF form. So we have them on the website in website form. So if you access them on things like your phone, it's easy to view, but we do actually have them in PDF format for each of them. So they're relatively easy to print as well.
It looks like there's a question about combining different years. So Ben, do you mind if I attempt that one? You can add on. So someone asked about difficulties or challenges combining multiple years of the caregiver module, since there have been some changes over time. And yes, I would just say, just be aware of what those changes are. So some questions, including the main screening question, has not changed. So the identification of caregivers didn't change between 2015 and 19. So the basic prevalence across time should not vary, by year or by state. But like I said, some response options have been changed slightly, especially in that health condition question and also the relationship question. Some of the response options changed. One approach could be if you collapse categories in a way that, for the relationship one, I think we added different versions of unmarried partners, but if you created sort of a spouse or partner category, that might help address it. Or, you might need to just focus on a particular year if you really want just one set of consistent responses. Oh, and someone else asked about having any policy variables that might affect caregivers in BRFSS, and sort of like Ben's response to the earlier question, the short answer is no, there's not any additional sort of state level information or policy level information in the BRFSS. It's not linked to anything else. It's all self-reported information from respondents. However, if you know what is happening in certain states, then you could create a state level variable that represents some aspect of caregiving policy and include that in your analysis, but no, it would not be included with the data set itself.
And to add on to Aaron's answer there, there are also a lot of questions in the BRFSS that might be of interest to policymakers. So for example, you can look at whether or not caregivers have health insurance and things of that nature. So even if, that's not specifically asked in the caregiving module, again, the nice thing about the BRFSS is you can cross-link that those responses about caregivers, whether or not someone is a caregiver, some of the other questions, to some of those other factors that are captured within the BRFSS that might be, more specifically related to a particular policy interest of yours.
There's also a question about whether, it's framing it around COVID-19, highlighting a lot of the inequities and inequalities in health that we've seen nationally, including financial situations. So someone was asking if there's information about income and poverty status in the data set. There is a question about household income. It is a categorical sort of response. So you could match it up, for example, with whatever the federal poverty guidelines are. And it also asks about household size. So again, you can calculate income for the person's given household size. There's also other information about education and employment, sort of the standard sociodemographic variables. Ben, can you think of anything else that might be?
Yeah, and then there's actually a similar question in the chat that asks about the estimated potential financial costs associated with caregiving. So things like societal costs because someone had to drop out of the workforce. And I would just note that the BRFSS doesn't look at things like indirect costs, which I think is a little bit getting at what you're talking about, but we do work with other stakeholders such as AARP and the National Alliance for Caregiving, and they do release reports that look at some of these other kind of indirect costs or other financial burdens that are not captured within the BRFSS. So even if it's not captured, in the BRFSS, there is caregiving data out there through some of the other great analyses that have been done.
Like there are also a couple of questions about sub-state geographic levels, and there is, as of 2018, there is a new variable that represents rural and urban status, but there is not county level, for example, indicators in the public data set, and I don't believe, and zip code is not publicly available in it either. I don't believe that there in the public file there's additional information, but it might be possible to contact your state BRFSS coordinator and get a state level data set that has some separate indicators. I'll give you an example from here in North Carolina. I worked with my state office. They don't release zip code data to researchers either, but I was able to work with them to get an indicator for people who lived in an Appalachian county in the state versus the rest of the state. And so that sort of thing might be possible. Ben, do you have any other geographic division information?
I don't have anything additional to add, no.
And I will just also mention CDC recently launched the Places website that has smaller area estimation using multiple data sources. And I don't as far as I'm aware, caregiving information isn't on there yet, but that might be somewhere to keep up with as well. I don't know what the plans are for the future.
There's one question that asks about whether or not there's an LGBT identifier in the module or in the BRFSS core. There is actually a sexual orientation and gender identity, or SOGI, optional module in the BRFSS, so that data can be linked to the other questions in the BRFSS. But again, that is an optional module.
Oh, and there is a question about collapsing some of the response options, specifically on the health condition variable, and that can be a challenge. As you might recall, there's quite a few options on there, and some of them tend to be pretty sparsely populated. For example, I think across states and across time, we haven't seen a very substantial number of people who report caring for someone with HIV. So, I mean, I think there's not really an easy answer in terms of collapsing those response options. Some people have done work, you know, where you combine any of the kind of chronic physical health conditions, diabetes, cancer, arthritis, et cetera, and maybe keep other mental health conditions together. But I think it largely just depends on what the intention is for the data and what you'd like to do with them. I would also mention that, you know, there's not always a perfect alignment between the amount and type of care that someone's doing and the health condition they report the care recipient had. So I would just recommend a little bit of caution in making assumptions about what type of things people are doing based on the health condition question. I don't know if that's actually helpful. Ben, do you have anything else to add there?
I don't. And so one question that was asked is, in contrast to family and friends as caregivers, sometimes people in physical proximity, like neighbors, are caregivers. Do the data identify physical proximity in between distance between the caregiver and the receiver? So that's not specifically asked in the caregiving module. However, again, I think family and friends is a fairly arbitrary category, so that should capture things like neighbors. If you're, you know, providing care for a neighbor, that would probably fall under something like friends.
Someone asked about the rural-urban classification. There's actually two different definitions in BRFSS, two different variables that have slightly different definitions. I believe they both use the National Center for Health Statistics classifications, but I will try to look up the documentation on that and
Yeah,
get you a better answer.
that's correct. It does use the
Okay.
NCHS urban rural classification scheme.
Thanks, Ben.
There's an additional question asking about persons receiving care who kind of fall into both the informal and formal care categories, and whether or not we are able to look at the proportion of each. So like when formal care is provided versus informal care. I don't have a good answer to you for that using BRFSS data. However, if someone self-reports that they're providing care, that doesn't necessarily mean that that person is not also receiving other kinds of care in other settings. So it's really specific to the caregiver and you know their caregiving situation, you know, so that they are specifying that they're providing care to an individual in an informal, unpaid way, but that doesn't mean that the recipient couldn't also be receiving other kinds of care.
There's also a question and sort of observation about the fact that because of COVID-19, more people may be providing some sort of basic assistance to neighbors, going grocery shopping for them and so forth, and whether that might impact the prevalence of caregiving that we see in the module during 2020 and 2021. And so I think that's a great point, and it's certainly possible. I think that looking at some of the hours per week and what type of care they're providing could help us distinguish, whether it's that pandemic specific type of assistance versus otherwise, but there is not, as far as I'm aware, a specific question related to COVID or about starting caregiving since COVID. Again, there's also a duration, so we might be able to infer whether someone started providing care after the pandemic or not. But it is a good point, and again, depending on your needs and your analysis, there is that main screener question, but you can of course subset or create your own definition of what qualifies as a caregiver for your purposes. So if you want to only focus on people who are doing personal care or providing a certain level of care per week, that's certainly something that you could make the decision to do within the module. And it looks like there's also a question about how state policymakers tend to regard these data and findings. And I'll just admit my ignorance here, since that's not really the level that I work on. Ben may have some thoughts, and I think actually the next webinar next week we'll go more into that topic area. But Ben, do you have anything to?
Yeah, I would also, reiterating what Erin said, I think if you attend the next webinar, or if you have the chance to review that webinar once it's posted, the Alzheimer's Association works fairly directly with some of the state level agencies and with policymakers. We as a federal agency aren't involved in things like lobbying and policymaking in that regard, so they would probably have more information about kind of how that has been used in that nature.
And then there was one additional question about accessing data. So yes, if you go to cdc.gov/BRFSS, there is a section of the website where you can download data for each year. And so that includes, it's aggregated already across all the states and territories, but you can select within data sets once you download it, your own state or territory, if that's what you're interested in. You wouldn't need to go through your state coordinator unless the state added, so we didn't talk about this, but there's an additional category of questions which are state added questions, and those don't appear in the public file. So only core and the optional module questions appear in the CDC's public file, which the caregiver module is an optional module, so it's in there. But if you had anything additional at your state level that you wanted, that's the only reason you would need to contact your coordinator to get data. Otherwise, you could just use the public file.
And they do provide the data in a pretty easy to use format. So for example, if you use SAS for coding, they provide SAS data for you. That's really quite easy to transition to your own personal work.
Absolutely, and there are already some calculated variables in there for some of the risk factors and things that you might want to look at. So it's a very clean data set, very user friendly. And as I mentioned before, the statistical guidance, there's both a BRFSS user's guide, which I highly recommend the first time you use the data. And then there are some of the specific guidance documents. As I mentioned, there's one for the caregiver module that has some SAS and STATA code in it as well.
And in terms of the timing with which the data is released each year, it's generally released 1 year after the data is collected. So for example, in the 2019 BRFSS, that data would be released in around the fall of 2020. And generally we update our things like infographics and our data portal sometime in the early spring of that following year. So for example, this year, we would be uploading the 2019 data to our website in early spring 2021. And I think that that's all the time we have, but feel free to shoot us any additional questions that you have via email, or and please do attend the next webinar if you have the chance next week to answer some of those policy related questions. And I believe that the other webinars that have previously taken place the last 2 weeks are posted on the GSA website.
Yes, thank you. I'm sorry we've run out of time. A huge thank you to Dr. Bolden and Dr. Olivari, and also to our attendees. So this is the end of our program.